For joining us. Let's go through some introductions, please, if you guys want to start.
We'll start in the top. Dr. Jan Hoonan.
Hi, I'm a pediatrician in Elko.
Welcome. Got Alan. And then Tom Berg.
Good morning, everyone. I'm Tom Berg. I'm a medical liaison with Eli Lilly and Company, supporting clinical education and medical research, covering Arizona, New Mexico, and Nevada. And the reason why I'm on the call today is because I work very closely with the New Mexico chapter of ECHO.
Oh, great. Welcome. Thank you.
Hi, I'm Evan Klass. I am an endocrinologist here in Reno and somewhat involved with Project ECHO for a while.
Krista, are you okay to talk to us? I know you're driving.
Yeah, I'm at a stoplight, so I'm okay. I'm Krista, C-Cord nurse practitioner from Elko, and I'm like Dr. Klass. I'm kind of somewhat involved, you know. So I've been doing it a long time. Don't know how I could practice as well as I do without it. So.
Awesome, great. Hi, Dr. Van Gilder.
Hi there. Dr. Van Gilder out in Lovelock, family doctor. Just very appreciative of ECHO. Thank you for all your help.
Nice. And then Nicole.
Yeah, can you hear me?
Yes.
Okay, I'm a PA here in Reno. I work in a pediatric office.
Awesome, welcome. So good to have you.
And I'm Kathy Eckert. I'm a pediatric endocrinologist.
I'm Yolanda, and I'm a registered dietitian and a certified diabetes educator working in pediatric endocrinology with Dr. Eckert.
I'm Steve Graybar. I'm a clinical psychologist, and I work in the Department of Psychiatry here in Reno.
So today we're going to go through differences between types 1 and 2 diabetes, as well as some other types, monogenic diabetes and maybe some neonatal diabetes. And this time I've kind of done it more in a case type form as opposed to just didactics. So I'd love to have this be an interactive session. And as you can see, we have some logbooks that we'll go through too, just kind of to go through different types of insulin and how to troubleshoot abnormalities in blood sugars. This is really geared towards children, and that's really all that I see. So, you know, there are some differences in terms of what children do and insulins and so on. So just kind of bear that in mind, please. Okay, so let's get started. Sorry, clicker, or you just, oh, thanks. All right. Okay, so the first one is a 5-year-old female who comes to the office with her mom, and her mom says that she's had the flu. And she's been sick for the last 2 days and vomiting and some low-grade temperature, but really nothing too concerning in terms of her fever. But she just continues to vomit, and this is really not very characteristic of her. On exam, she appears mild to moderately dehydrated, and according to your chart, she's lost about 10 pounds since the last visit 6 months ago. On exam, she also is breathing very deeply and is irritable and appears to be very uncomfortable. So what does this bring to your mind? Initially, obviously, we're talking about diabetes, so I'm giving part of it away. But given the scenario with a 5-year-old, what type of diabetes do you initially think about?
1. Type 1.
Yeah, and it's not to say that you can't have a 5-year-old with type 2. Unfortunately, that's the way our society is sort of going. The youngest person I've ever had has been 8 years old when he was diagnosed with type 2. So it can happen. I didn't give you the weight other than to say she's lost 10 pounds. So I guess it's safe to assume that she's relatively thin. So absolutely right. You know, we would assume this child has type 1 until proven otherwise. So initial blood glucose is 589. Her sodium's low, potassium's a little on the high side, CO2's 7, and her venous pH is 6.9. So this child's pretty sick and probably has had hyperglycemia for several months, and then in the last couple of days is really decompensated, and the acids have built up to the point that she's Kussmaul breathing now. And so, you know, we hope, of course, that we don't find children in DKA when they first present. but at least 50% of the time, that's exactly how they present, in sort of dire straits. And in hindsight, the parents state they've been peeing a lot, drinking a lot, had some weight loss, plus minus eating a lot, depends on the age of the child. So with this child, in the emergency room, we begin with fluid resuscitation, although unlike adults, you have to be a little bit careful with that, not to fluid overload them, because they are at risk for cerebral edema. So typically we start with 20 cc's per kilo, unless they're really shocky, and then you can go up as high as 30 or 40 per kilo. And while they're in the emergency room, or if we're planning to transition, no matter where these children are, if they're at an outlying hospital, even in Reno, we usually do not begin insulin. And the main reason for that is hypokalemia. Can be a result of dropping your blood sugars too quickly and the insulin directly shooting the potassium back into their cells. So even though it's just so tempting because the blood sugar is so high, we really try to reserve insulin for once they're at their home hospital and in an ICU setting in this situation. So fluids are really what this child needs to help resolve the acidosis and to help with blood pressure and shockiness, etc. Okay. So the usual regimen that we start the children on is some form of long-acting insulin, Lantus or Levemir, and usually 0.3 to 0.5 units per kilo per day. So the younger you are and the less sick you are, usually the lower dose we start of Lantus, whereas an adolescent would get about a half unit per kilogram per day. Okay. And some people, if they've had hypoglycemia for months and months and months, they don't have any reserve left, but oftentimes there's a little bit of reserve. So once you get them out of DKA, then their doses tend to go down a little bit more, okay, at least temporarily. And then as they go in the honeymoon period, then we also see some decrease in their doses. And then the other part of this is we give them short acting. And we don't typically do sliding scales per se, otherwise you're kind of always chasing your tail on these. So what we set the children up with is a carb to insulin ratio, as well as a correction bolus. So typical, and again, the older someone is, the more insulin we tend to give them. So a 5-year-old, we probably start on a unit for every 20 grams of carbs, and an adolescent probably 1 unit for every 10 grams, because they're much more insulin resistant because of puberty and growing and so on and so forth, okay? And then a correction, a good place to start is 1 unit for every 50 points, with their goal being 150 glucose, okay? Now, important to note, because a lot of times what happens is parents will see a blood sugar at, let's say, 3 p.m. in the afternoon. They're gonna have a snack and they wanna give insulin for that. But let's say the blood sugar is 350. The first thing they wanna do is give a correction as well. And we really try hard not to do that, because otherwise you're bouncing up and down all day, and it's very difficult to tease out which insulin is wrong, okay, if it's the ratio, if it's the correction, if it's the Lantus, if we're constantly giving corrections. So in the hospital setting, we might do that, but as an outpatient, we really try to reserve those corrections for just at mealtime, okay, and let them ride. And one thing I always tell parents, especially when they first come home from the hospital, because they want the blood sugars to be perfect. In the hospital, they're certainly not perfect, but we get them down hopefully in the 200s, knowing that once they're home, they're more active, food changes, and so on. But we have them call in every day after they go home. And I have a lot of parents who are very concerned that the child's blood sugar is 250 or 300. And I reassure them that for months before the child was diagnosed, their blood sugars were way higher than that. So we're not causing any long-term harm. Okay? They may not feel good and they may feel a little irritable, but we're really not causing any long-term harm. So it does take weeks and weeks to get their blood sugars back down to the normal range. Okay. All right. Do you want any?
Yeah, especially as I try to emphasize that we're trying to bring them down pretty slowly because we're avoiding any lows, and we're worried too that the honeymoon's going to kick in, and we're still trying to figure out sort of what their body's doing. So just assuring the parents it's better to bring them down nice and slowly. We'll keep sort of chipping away at it is the better way to go.
Yeah, absolutely. And also, kids don't feel good when they go quickly from 500 down to 150. They get very grumpy. Their vision changes. There's all kinds of things that are happening. So again, going gradually, like Yolanda mentioned, is really important. And also the risk of hypoglycemia, especially in the younger kids who don't necessarily feel it. They can easily go down to 70 or 80 before they feel anything different. And then that's not that far away from being a 50. And a 5-year-old, for example, can't treat him or herself. So you have to be really cautious with that and avoid hypoglycemia. In the younger kids, within reason, I always err on having higher blood sugars rather than low blood sugars, because you can cause some neurological problems with that as well.
I think warning them too that if the kid's been running in the 400s for several months, that 180 might feel pretty lousy. So they'll describe hypoglycemic type symptoms and they're okay. But just sort of mentioning too that that's sort of your body, your brain's actually adjusted to those higher blood sugars. So it feels low, but as the blood sugars start to come down, that'll sort of fix itself.
Any questions on that first case?
Well, could I jump in for a second?
Please.
Just really quickly, I know everyone knows this, but just to underscore that at this point, parents are probably taking in 10% of what you're saying and about 5% of what's actually happening. And they're gonna have to just keep hearing this and digesting this over and over and over and over. I mean, we fly through this at the speed of light because it's so familiar to us. They're just not hearing it. That's been my experience in the PICU.
Yeah, and that is one of the reasons too, we have them call in every night or every day after they're first diagnosed. Because this is really scary. You know, we can all probably relate to bringing home a newborn baby, but there's some instincts there, and maybe your parents or your grandparents are involved so they can help you. With diabetes, it's not that instinctual, and especially when we're throwing all these numbers at them, and nobody probably in their family has any experience to help them out. So we have at least once a day contact with them, and a lot of that is just what Steve was saying, is some education as well. So it's not just about the numbers. It's here's what you do if the blood sugar is low, and even some basic carb counting. So sometimes these conversations are fairly long on the phone. Okay, but it is important, and for long-term education, it really shows eventually because the parents then understand it.
Yeah, I think I have the luxury of being able to sit with patients for an hour and a half. The physician doesn't necessarily have that. So, and probably sort of in Steve's realms, I try to always sit down with them and just like, so how's everyone feeling? Or it's a new diagnosis, you guys surprised, angry, frustrated, and get them to sort of get that emotion part out of it and sort of sort through that. And then I actually find that we can get through the other stuff quicker if we address sort of that emotional stuff ahead of time. Just like let them say they're super angry about it or they're super scared, and then we can sort of tackle carb counting. Yay!
Yeah, there's questions?
Yeah, Dr. Eckert, thanks for the case presentation. You used the example of a 5-year-old in this presentation, but is there a typical age range where you'll see the presentation of type 1 diabetes? Does it happen earlier, the time of birth, or during the earlier ages before 5, or can it sometimes occur after 5 years of age if it's type 1?
Sure, that's a good question. So, the demographics of babies have kind of changed really over the last several years. It's been very interesting. So we're seeing a lot more younger kids, some toddlers, 9 months, 10 months old, and certainly some 1 and 2-year-olds, which when I was in fellowship a long time ago, I won't say how long, we just did not see that. And so most of the kids were probably 5, 6, 7, and then another burst right in the teenage years. And so it's really shifted. I mean, the other thing that's really interesting is there tends to be some seasonal variation as well. But even within that variation, that's changed a lot too. Every Thanksgiving, we used to get 6 or 7 new onsets. Okay? And now, well, this year we had a couple. But over the past several years, we just haven't seen that. And so we see different clusters at different times. And it's probably all related to whatever virus is going through the community. But we also do see clusters of kids coming from Gardnerville or Fallon, so we'll get 2 or 3 in a month-long span, for example. So it's probably the same virus that's running through there. So what's important though is that we're only talking about pediatrics here, but it's important to know that years ago we'd say if you're past 40, it can't be type 1. There's no way it can be type 1. And now we know that that's just not true. I mean, there's 70-year-olds, 75-year-olds who now are being diagnosed with type 1. Whether or not it's classic type 1 with antibodies, I don't know because I don't see those patients. And we're also knowing now that there's a lot that isn't type 1 and it's not type 2. And we're going to talk a little bit about that in just a little bit. So the monogenic type of diabetes. So bottom line is, suspect type 1 in anybody if they present with classic symptoms. And a lot of times what we see, particularly in adolescents, is someone, overweight adolescents, I should say. Everybody assumes that it's type 2 because they're overweight. But 30% of the population in childhood now is overweight. So you cannot use that as an exclusion. And acanthosis nigricans being present is also not an absolute either. Yeah.
So just kind of piggybacking on that and jumping back to the education comments, one of the things that I've noticed, especially with the teenagers, is insulin. They hear insulin makes your sugar go away, but it doesn't make the calories go away, and that seems to be a real common problem. So insulin doesn't mean you get to eat anything you want. That could be really stressed during the education too. So yeah, that's been a problem with pretty much all of the type 1s I've had.
No, that's a great comment too, because, and that goes both ways, so some people say, well, I can eat anything I want and just take insulin for it. But then they also learn that the corollary to that is if I eat a lot of food and I don't take insulin, I'll pee it right out. And, so that's turned into an eating disorder associated with type 1 diabetes. We're going to talk a little bit later too about this concept of kind of grazing all day and not taking insulin for all of it, or talking about free foods that don't need insulin. Well, it's only free if you do X amount. So Yolanda's actually going to address that a little bit in just a little while too. Okay, so let's go on to case number 2. Oops. Okay, so I might have given away some of this, sorry. All right, this is a 13-year-old Hispanic female. Presents to the emergency room with abdominal pain, vomiting, and dehydration. She's lost 10 pounds over the last month and now weighs 225 pounds. So blood sugar's pretty high, 289, sodium's a little low, and otherwise okay with the exception of the CO2 being low. So this girl has metabolic acidosis and has hyperglycemia. So by definition, we don't know what the ketones are, but really she has diabetic ketoacidosis. Okay? Now, this is in stark contrast to the first one that I showed you. So this is really more of an enigma. What would you think right off the bat? Is this type 1? Is this type 2? Any takers?
It looks like type 2, you would think type 2, but with the CO2 being low, you really have to think that it's type 1 or the combo.
Yeah. And so it's hard to tell. I didn't tell you about acanthosis, but again, that's not an absolute. But I think what's important to know is that it's really, really hard to know. But once anybody's in DKA, whether we think they have type 1 or type 2, you need to treat them with insulin because they're going to be resistant to insulin, but also very low in terms of their insulin production capabilities. So the blood sugar, the higher and higher it gets, and the more you try to make insulin, it can become somewhat toxic. And so even if you are a type 2 and theoretically can make insulin, oftentimes it shuts down. So they can present in diabetic ketoacidosis. Okay? So obesity is almost universally associated with type 2 in adolescents. And again, there's some crossover with some of these other non-type 1 and non-type 2s we'll speak about. Ethnicity, higher in Hispanics, African American, American Indians, and Pacific Islanders. Interestingly, I actually work at the Tribal Health Center, and we have many, many very obese patients over there who are teens who don't have diabetes. Severe acanthosis, severe obesity, and they just aren't getting diabetes. I'm waiting for that to happen. But it's always amazing to me the reserve that they have. And you ask the parents and they develop diabetes in their 20s and 30s. So probably imminent. It's just not happening too early. So the thing with type 2, particularly in adults, is oftentimes they present with complications already at the time of diagnosis. nephropathy and retinopathy and so on, because it's so silent for so long. In the adolescents, we tend to see it present more dramatically and earlier, fortunately, in some cases, so that we don't necessarily see those complications. But a lot of times there's already some proteinuria because of their type 2 diabetes. So how do we tell then in this particular child? If we were to check a fasting insulin right now, that's not completely fair because she's probably going to be insulinopenic. She's really sick. She's acidotic. If this person came into your office and had a fasting blood sugar that was 200, you could do that and perhaps tell what the insulin level was, and that'd be accurate. So in this case, we'd have to really look at those antibodies, the GAD65, islet, and insulin antibodies. The A1C does not distinguish, especially when they present in DKA, because with that, you have to think that they probably have had hyperglycemia for a very long time, months most likely, in order for them to go into DKA. Either that or they got a bad stomach flu on top of some moderate hyperglycemia. Okay? And then family history, almost everybody that I ask, whether they're coming in to be seen for diabetes or not, almost everybody has a family history of type 2 diabetes, or at least that's what it's being called. I guess we don't really know for sure. So that's not particularly helpful either. So in this particular case, you really have to look at the antibodies in order to tell. But the safest thing to do, because those antibodies won't be back for maybe 2 weeks, safest thing is to keep them on insulin even after the DKA has resolved. You can consider putting them on glucophage as well, and that may help as an insulin sensitizer, but probably won't do it alone, okay? And especially if it's a type 1. Okay, question. Yeah, question?
I think you were just going to hit on it. So I was just going to ask, so does the differential diagnosis impact the treatment that you give at that moment, depending on if it's type 1 or type 2, or do you just treat it the same way until you find out?
Exactly. So if they come in DKA, you have to treat with insulin. And metformin is actually contraindicated if you're in DKA. It can worsen metabolic acidosis. So yes, we treat them just like a type 1 and then try to figure that out thereafter and then decide what the outpatient protocol is going to be. So yeah, good question. Okay. Do you want to add anything to that as far as type 2s?
No. That was my thought, was check antibodies.
Yeah. I think, and I don't know if everybody here hears this too, but a lot of times what I hear from families and the patient themselves, if they're old enough, is, oh, I really hope it's type 2 because that's easier. And that's just a pill. And, then I don't have to worry about all this other stuff. And, when patients ask me, which one would I rather have? I say, I take type 1 in a heartbeat. Because it's more apparent and you know exactly what you have to do and fewer complications, at least short term. And obviously it depends on how well you take care of things. But the other piece of that is, typically there's already comorbidities and typically there's obesity. And so it's just more difficult, I think, to lose the weight and try to maintain your blood sugars as well. So it's kind of a misnomer in my mind, at least. I don't know what your experience has been, but a lot of people just take type 2 for granted and think it's just one of those things that's going to happen to them and they're not going to really do much about it except take the pills. And that's really saddening to me because when adolescents get it, by 30 or 40, they're going to have a lot of problems. Steve, do you want to chime in?
No.
Okay. So the third case is a 14-year-old male. He was seen in the emergency room with moderate exacerbation of asthma. He was given Solu-Medrol 40 milligrams in the ER, and 3 hours later, his blood is drawn, which shows a blood sugar of 172. All the other labs are normal, including the CO2. Because of the elevated blood sugar, an A1C is drawn, which was 6.4%. What do you think about this? What could this be? Any ideas?
It's probably from the Solu-Medrol. His sugar's so high, so he's pre-diabetes.
Okay. Yeah, and that's the tough part, is how fast does soluble will make your blood sugar go high, and how high should it go? So we'll see kids in the ER, especially little kids, who come in with really high fevers, or maybe a febrile seizure or just a regular seizure, and they check their blood sugars, and they're as high as 180, 200. And most of the literature would suggest if you go into 150, that's probably because of the stress that they're under. 170s, 180s, that's getting up there. And then once in a while we get these 200s, no steroids. So what do you do with that? And it's always a tough question. So they drew an A1C and it's 6.4%, so a little bit high, but not like our other cases probably presented with a 11 or 12%. So this happens relatively often, and including in our clinic, where someone might have just checked a random blood sugar, or at one point they did a urine and there's some glucosuria in there, mild to moderate. And so this can be really tricky, and until probably 10 years ago, we really didn't know what to do with this. Now we understand it a little bit better, that maybe it's some of these unusual types of diabetes that we used to think were very, very rare, the monogenic or the MODY type of diabetes, maturity onset diabetes of the young. And I'll show you a graph in just a second of all these different types. So after the A1C, we get a little more history, and the mom was told that she had borderline diabetes during the pregnancy. She's had a blood sugar check multiple times. It's usually about 130, and her A1C is about 6.5% each time it's checked. Now, interestingly, a lot of these moms in the past have been put on insulin during pregnancy or sometimes oral agents, and you don't really see much in the way of changes in their blood sugars. And so once the pregnancy is over, they take them off and they go about their business and may or may not get their blood sugars checked. So most likely that mom has a form of monogenic diabetes, and so does the son. They are autosomal dominant for the most part, and a lot of times they just don't get picked up. Or later in life, they may get picked up with a moderately elevated A1C. So the most common form is MODY type 3, you can see in the graph here. And the thing that's most important about this is you can treat these with sulfonylureas. And there's also a neonatal diabetes form that usually presents typically before the age of 6 months, but at least before the age of 1. And in the past, these were not known how to treat, okay? So I'll give you a case that we had in our own clinic where an infant was born to a mother that I actually took care of in her young childhood and adolescence. And we treated her as if she had type 1. For all intents and purposes, she did. And so she was on fairly high doses of insulin, not very well controlled. She came back when she was pregnant, had this child, and in the NICU, this baby actually developed significant hyperglycemia. With that, we said, well, yes, Mom, we now know about these mutations in the insulin receptors and insulin production, and maybe that's what you have. And sure enough, both of these people had the same mutation, okay? Now, the important thing, too, about the neonatal diabetes is many of them, as in this case, can be treated with sulfonylurea. But this mom was very resistant to that. And in fact, her mother had been diagnosed at 2 months of age. At the time, she was in her 50s. When we touched base with her again, she had been diagnosed as an infant as well. So both the mom and the grandmother were on insulin. When we told them this and said, hey, we can get you tested for these mutations, they were very reluctant to do it. Once we finally got it on the grandmother, we said, hallelujah, you can come off insulin and go on to sulfonylurea. She did not want to do it. She'd been given insulin for 50 plus years and did not want to switch over. So it's really interesting to me that you can get so used to something and it can be kind of scary to switch over. But if we catch these and we can actually diagnose them, you can get the genetic markers now done through the University of Chicago, usually for free because it's part of a study. And so we can make a huge difference in these patients' lives. And oftentimes, sulfonylureas are better, and A1Cs are much better than when they're on insulin. Okay, so I would just suggest to you to kind of think about it, that not everything's type 1, okay? There's this huge gray area in between. And so think of these. MODY type 2 is second most common. MODY type 3 is the very most common, okay? And you can read what the typical age and clinical presentation is. Okay. Any questions so far about any of the cases or the monogenic diabetes? And by the way, the reason it's called monogenic is, well, there's one gene, but also we tend to consider type 1 and even type 2 as polygenic. So there's some genetic background that predisposes us to it. But as opposed to the monogenic, you need something else environmental to really trigger those. Okay, and these you're born with. There's nothing really that you can do to modify those for negative or positive. Okay, if there's no questions, I'm gonna turn it over to Yolanda for some nutrition issues.
So, sort of goes back to the you can eat whatever you want thing, but at the beginning, we're really, really careful to assure families and the patients that they're going to be able to eat and they're going to live a normal life. They're going to be able to eat all the things that they did before and try to be, that this isn't going to be this big, horrible thing. That being said, I always cringe a little bit because I was a dietitian before I was a diabetes educator. And so I have a little bit of an issue with saying, oh, you can eat anything, because we do want to raise healthy eaters ultimately, but we don't want to go in at the beginning and you've got this new diagnosis, you're overwhelmed, and then say, you're never going to be able to eat anything fun again. You'll never eat birthday cake, so we have to try to balance that. So it's important, I think, to hear the family's concerns and show empathy, obviously, but then staying really positive. And then I slowly try to start chipping away at moving them towards a healthier eating style. So I'll try to, minimize the change at the beginning, and then we start to sort of slowly working into small changes. My quick approach is just to run through a typical day with the family. It's pretty fun to do. I like to ask the kids some of the questions and the parents some of the questions, and I'll switch really quickly because what they tell you are completely different things. So if you ask a parent like what their kid eats for breakfast, they'll be like, oh, well, we have, they always say things that they think I want to hear. So they'll say, oh, well, we have Cheerios every morning for breakfast. And I don't know, plain yogurt. And then you ask the kid, so what'd you have this morning on the way to your appointment? And they'll tell you 6 donuts from 7-Eleven. And it's like, okay, so you always get 2 different answers. And I try to switch really quickly back and forth because it catches everybody off guard. It's all just a big game for me. So you can ask, what do you usually eat for dinner? And it's like, oh, there's always vegetables. And then what'd you have last night to the kid? And they'll be like, I had 6 pieces of pizza. But I try to go through the sleep schedule first. So what time do you go to bed and what time do you wake up? Because I feel really strongly that sleep dictates so much else of what's going on. And I always feel like it gives me a big idea sort of what's happening in the family, which is sort of the dynamics are like. And so I always ask what time they go to bed at night, what time they wake up in the morning. And then I go through not so much what do you eat for breakfast, but when's the very first time you eat? When's the next time you eat? When's the next time you'll have something to eat? And that you seem to get a better, like a true vision of what the day is, because then I'll tell you, oh, at school after recess we get a snack, and that just gives me more clues about sort of what's happening. Try to include input from all the family, make sure I include beverages. I'll ask about beverages while they're telling me about each of their meals, but then I ask about it separately too, because there's often a lot of Gatorades and juices and sodas and Sobeys and whatever else kids are drinking these days, whatever else sugary stuff that they're having. So I ask that in a few different ways. The entire time I'm trying to figure out where my big spots are, what are the big things that I want to try to address, how I'm going to address them without adjusting what they're doing too much. You want to sort of look at what their lifestyle is and what their flow is, and then interject small changes in there, and that's where you'll see the most success. I think all of us know that if we're like, here's a 1,500 calorie meal plan, everyone's going to be like, good, and toss it in the garbage. So as much as I can not disrupt what they're doing already, better it can go. Then I try to do some sort of education that's going to, Steve taught me all of this, motivational interviewing, I try to teach something that's going to lead them to decide that that's what they should change. That makes sense. So I might teach them about oh, the difference between how an apple is going to break down, how quickly it's going to enter the bloodstream versus applesauce versus apple juice. But I'll teach it more from a like, ooh, listen to this, you know, this has to happen. And then say, so what do you think you might want to change? And they will say, wow, it sounds like juice isn't a great thing to do. And so they own the choice, they own the decision. And then it's not me dictating to them what to do, because we know the second we tell someone you should never drink juice again, they like go buy a gallon on the way out the door. That's the worst thing you can do. And sometimes we'll even do things if they're eating McDonald's every day. They'll say, well, maybe I'll never eat McDonald's. Like I shouldn't eat McDonald's ever again. And I'll say, how about we have it on Tuesdays and Thursdays? Because it would be hard to cut it out altogether. And then they come back and they haven't had any McDonald's. They're kind of like so stunned at the fact that I'm telling them that they can go to McDonald's twice a week that they don't get it at all. Where if I told them, you know, all the horrible things about McDonald's, they would probably pick it up on the way home. My personal goal is always to have them walking out the door thinking like, that wasn't as bad as I thought it was going to be. I think I can do this. So I try to be, that's just my thing. That's my favorite thing is when people walk out the door and they think seeing me was going to be worse than going to the dentist. And they're always like, wow, I feel like I can do this. She said, just don't drink sodas except for on Friday or whatever it is. Typical areas to address, lots of juice and soda. That's the very first place I'm going to hit, is to try to cut that back. I will probably, if it's a type 1 and it's a little kid, parents have all the control, I would try to have them just not buy it, because newsflash, if it's not in the house and your kid's 4, they don't drive, they don't make money to buy juice. And so I try to empower them to, well, just don't buy it. Yeah, I can tell a million stories about that. I look for long hours between meals when kids are going, you know, they eat lunch at 11 o'clock and then they, gosh, middle schoolers, they eat like 10:30, 10:45. And then they're not eating again for several hours. And they come home after school, they're starving. And so then they'll start snacking, and they don't want to take a shot. So they think that they're going to get away with just doing like a string cheese and then maybe doing another string cheese and then doing another string cheese and an apple, and they're still under 20 grams of carb. But it keeps just sort of adding up. So I like for them to just go ahead and like sit down, have a meal, eat something, have a sandwich, and I don't know, some fruit and some carrots or a handful. That sounds ridiculous. They're not going to do that. Have a handful of chips and take a shot for it instead of sort of nickel and diming themselves. Just sit down, eat your meal, and take a shot rather than sort of, like I said, nickel and diming yourself, grabbing things. Meals without protein are a big issue. Doing like waffles and syrup, things that have a lot of carb, just going to enter the blood sugar a lot quicker. I'll explain to people that, you know, carbs' job is sort of to get energy out to the cells, but protein is what sort of sits in our stomach and makes us feel full. And so cereal's a big one. If they just do cereal for breakfast, you see these huge spikes that are hard to ever really get down. It really raises them and sort of leaves them up for a long time. So I'll work on, you know, peanut butter and toast, or an apple and a handful of almonds on the way out the door. If they were skipping, or if they were doing a lot of cereal, I would try to get them to do maybe hard-boiled eggs. Lots of ideas, I think, or what parents want. Can you guys think of anything that's like big areas? Those are them.
The free snacks. I mean, what we see a lot is Johnny comes home and eats 5 string cheeses because they're free. And obviously they're not if you eat 5. They are if you eat 1, but so that can really add up. And the parents may not realize that either. And there's some long unsupervised hours. So yeah, all the free stuff and some of the sugar alcohols that then cause other problems, diarrhea and bloating and stuff. And then that throws off your next meal and so on.
Mm-hmm. Yeah. So much better for them to just sit and eat. And I think psychologically, it's probably better too for them to just sit and have a meal than keep thinking. And this is true for adults too. We feel like, oh, I'm going to be really good today. I'm not going to, you know, snack between lunch and dinner. But really our brain and our body needs that fuel. And so you're better off to just plan and have a good snack than to say, you know, oh, I'll just have an apple, and then you're still hungry, and you have another apple, and then you're still hungry, and you grab a bag of chips. So it's sort of like just have a half a sandwich or have some peanut butter on toast and call it good. And that will help actually sort of stabilize their blood sugars, and then hopefully keep them from overeating at dinner, because then they don't go into dinner quite as hungry too. For younger kids, I look really carefully too at how far apart their meals and their snacks are, because I feel like I can get a tighter control if I'm really predicting how their blood sugars are rising and falling, and when we can throw a snack in and how big that snack is to get sort of a tighter range. That makes sense.
Okay, I jump in for a
I
second.
think Dr. Claus. Oh,
So, are you making any specific recommendations about fat content these days?
it depends on who it is. It's not usually the biggest thing that I will find. I usually find something else that's going to take precedence over that. If it's somebody that's super on top of it and they're looking at fat, I actually worry that they're being too controlling.
Yeah.
Does
I
that make
agree,
sense?
actually. I think that we perhaps, that's another very common misconception these days, that dietary fat is the enemy. And in fact, I think it contributes to satiety in a big way. And
Right.
Yeah,
I absolutely agree. And so I guess I'm a big fan. I'm trying to think of the proteins that I suggest a lot, or like cheese, cheese and fruit, apple slices, Havarti on a pear sounds really good right now. Or I feel like I always have more suggestions when I'm hungry. But doing cheese, hard-boiled eggs, I think is just a good one, because you can do 12. You can actually be so lazy as to buy eggs that are already hard-boiled, which my husband thinks is like the most ridiculous thing he's ever heard of in his life. But those are quick things, and you just have to, I encourage families to always have something readily available. Trail mix has a few M&Ms in it. The dried fruit actually drives me more crazy than the M&Ms in there, but you've got some nuts. Yeah.
So does this mean you did not eat breakfast this morning?
Yeah, I did. Do you want me to describe it? I had scrambled eggs with lox and avocado, because I do think the fat in the avocado contributes to satiety. And then I grabbed a Pop-Tart. I'm just kidding. Did you have something, Steve?
Yeah, I'm fasting.
Oh.
Just really quickly, because I know time is an issue, and I'm going to run as well. But for all of this, in every interaction, really quickly, there's two components: content and process. And what happens, because we're all pressured for time, and in family medicine, you have 11 minutes with each patient. We are driven by content, and especially early on around the diagnosis of diabetes, to be driven by content is to feel the pressure and the anxiety of transmitting this information. But if you are focusing exclusively on content and not on process, process is the relationship that's occurring between you and your family or your patients. You ignore that to their peril. If people don't seem to be grasping this, if they don't seem to be paying attention, for me, if they don't have sufficient anxiety around this consultation, or if they are consumed and overwhelmed by anxiety, and we pour through our sort of content agenda, it will all be for naught, and you'll be repeating it over and over and over. I used to think that we send people for diabetes education when we're angry at them. It was a form of punishment, right? But I say that lovingly because we're ignoring the process. If a family's being torn apart by this diagnosis, as Yolanda said, the first thing she does is she lets people talk about what is this like for you. To not do that is to not address probably the number one variable that interferes with people actually absorbing the information you want them to take in. So I hope that makes sense. I know you probably all do that intuitively, but I know that both Kathy and Yolanda do this expertly. I've seen them with patients over the years, and you just stop an interaction when a kid is running wild, in your office, the parent is anxious, they can't possibly be listening to you, you have to stop it. And you have to stop the interaction and address what's going on, and is this common? Or noticing, is there a dad? Who's going to be doing most of this work? Well, my experience is 90% plus are moms. And you must pay attention to see if mom is overwhelmed, or if she's depressed, or if she's simply not present for your meeting. I would suggest, and you guys can disagree, this is for naught. So to pay attention to how your relationship is going with these patients and these families, and what's going on in the families is crucial in terms of if there's going to be any take home from this incredible, important information. Is that reasonable?
Yeah, I think less is more, and so I think there's sort of this desperation. Well, they better know about checking ketones, and they better know about this, and they've got to know about that. And so there's definitely sort of this desperation. And I think dietitians just in general, we're pretty controlling, and so we feel like we can keep just handing information, and it's just not a good way to go. I mean, we want to give people resources, but we really want to focus on one or two things, especially if it's someone like with type 2 that we're going to be sort of working on this for a while. Just really try to focus on one or two things that they can do, make it simple, let them find success with that one thing that they're doing, and then continue.
Can I ask a nuts and bolts question? So in the setting of a newly diagnosed youngster, and again, this is really nuts and bolts, what's your typical process in terms of frequency of follow-ups? How do you handle that? How might, considering the constraints that we have being so busy and having to deal with payers, et cetera, how do you handle that in a practice setting?
So once they're discharged from the hospital, we have them call every day with blood sugars and troubleshooting, but we try to get them into our office within the first week or two. And then after that, usually about a month after, but it all depends on the circumstances. Ultimately, it's every 3 months. Some people need significantly more than that. I would say nobody needs less than that, because we've all seen it with any kind of chronic illness that you can rise to the occasion for this amount of time, and then it just kind of dwindles, and you kind of put it on the back burner, and okay, Johnny's doing okay, he's not in the hospital, so we must be doing okay. Because this is a lot of work, and it's every day and every hour of that day, and it doesn't go away. And in fact, it's even when parents are sleeping and when the child is sleeping. Most parents are still worried they're gonna go low in the middle of the night and have a seizure. There's all these huge things that many parents worry about, and that's tough. And so addressing those, I think, and bringing it to the forefront are important. There's also many families who don't know about that or can't grasp that, or it's so tough for them just to get through their day and have meals on the table. And we worry about those people a lot more, because those are the ones that kind of go unnoticed and until something really bad happens. And so one of the tricks is understanding where that family is. I mean, it's a psychosocial, it's an economic problem, it's all kinds of things. And so we really worry about the safety of those children, mainly for hypoglycemia, even though we tend to harp more on ketones and sick day management and so on. So does that answer your question?
It does. Yeah, thank you.
And then some, sorry.
I think during the first appointment too, it becomes pretty apparent how soon you're gonna wanna see them again. So whether it's just they're just gonna see me for education, or they're gonna have other families come in for just education or see the child, I usually get a pretty strong sense of like, how about 3 weeks? Or, we feel like we can go a month. I think there's a fair amount of people too that get overly confident and the honeymoon phase kicks in. They don't need very much insulin. They're smart and they can do the math inside and out, and they get all this sort of physiology concepts, and they scare me because it'll be like 8 months. We haven't seen the kid, honeymoon phase ends, and it's craziness. Yeah, so try to watch for that too, overconfidence.
The other really interesting thing is we try to give them the tools to make their own management choices. Because ultimately this is a self-managed disease. It should be, okay? What we find though, at least in pediatrics, is that almost nobody makes any adjustments to the doses in between their visits. I mean, it is so few and far between. And oftentimes when they do, they actually, let's say on the carb-insulin ratio, they go the opposite way. So it could, and it is kind of confusing. So if you're on 1 to 15 and you need more insulin, they think, oh, that's 1 to 20, when it's actually 1 to 10. And so they can get very confused. And if they're not calling in numbers or coming in frequently, you know, they'll go months and months. And by the time we see them, their A1C is 12%. And that's what we try to avoid by teaching them more. And even if that just means, hey, call us if you're having a lot of high blood sugars. We're happy to troubleshoot over the phone because many people live far away. Yeah. Okay. So we have a couple of logbooks we can look at. I also have an endocrine case that Raquel sent in. I think I'd like to do quickly, if we can, some of these logbooks because, does everybody have time still? Anybody need to go? You're all good? Okay. Okay. All right, so first of all, this is an optimistic looking logbook. We almost never get this many numbers, okay? This is just for our discussion today. So, and also the consistency of numbers for most of these, we never see anything like this, okay? But it's really just to show the point. And so what you can see here, and I'll kind of rush through this for the sake of time, that you know the most of the daytime numbers after starting at lunch are really good, okay? But then you see all these high numbers at breakfast. And so the first thought would be, oh, they're not getting enough Lantus at night, assuming they're getting their Lantus or Levemir at night, okay? Because you have these highs almost every day, okay? You have 185. But then if you look carefully, if you ask those parents to check some 3 o'clock numbers, you'll see there's a 52, there's a 32 on the 2 nights that they checked. So this patient is having a lot of rebound hyperglycemia, and all from a low in the middle of the night. Fortunately, they're not having seizures. There's nothing obvious that's happening there, but they're sleeping right through these on the other days that the parents aren't checking them. So especially the younger the kids are, I always check the early morning, and there's not a magic time, okay? There's no peak or valley, theoretically, to Lantus or Levemir. So you gotta check other times throughout the night if you are missing it. And I actually oftentimes will go down on the dose of Lantus before I will consider going up, because it's fairly likely that they're having some lows in the middle of the night. And especially if they wake up with a headache or you know, very minimal ketones relative to what their blood sugar is, sometimes that'll speak to having low blood sugars. Okay, so anybody have any thoughts about this one? Kind of erratic, and this is actually fairly typical of what we see. Okay, there's usually not a lot of consistency. So a couple of things, when we see numbers that are just all over the map, first you have to say, who's watching this child give the shots? Who's helping with the math? Are we doing the math correctly? And are we carb counting correctly? Okay, and those are all huge ifs. But if it seems reasonable that they're doing all of those things, the one thing I would always think of is, does this patient have lipohypertrophy? Okay, because sometimes the blood sugars are fine after a meal, and sometimes they're really low, and at odd times when the short-acting really shouldn't be even working anymore, you're having these lows. And so generally that speaks to somebody shooting into the same spot all the time. There's some scar tissue in there, so it doesn't get released right away. And so long after the food is already gone, that's when you get this surge of insulin and you have these lows at very odd times, okay? Does that make sense? Yeah. This happens a lot. And if you examine kids' bellies, and it's usually the usually the bellies, sometimes the booty, if the parents are doing it back there, they'll just keep using the same site because you lose sensation there. And that's what the kid likes, right? So especially if they're on their own doing their shots, we'll find little camel humps on their belly, and it's just really firm most of the time. Sometimes it's not as obvious, but at least think about it. And what I do is I'll take a Sharpie. If it's a boy, it's a pink Sharpie. If it's a girl, I'll take like a purple Sharpie, and I'll put a big circle around it and a big X through it. And then they know to avoid those areas. Okay. So in this one, they're waking up pretty okay in terms of blood sugars, but they're high the rest of the day, okay, except for their O300. So we can kind of guess that the Lantus or Levemir is probably doing okay. This is more a case of the short-acting insulin is probably not high enough, or they're not giving corrections, they're not calculating things correctly. So this is one that we probably start working on the breakfast carb-to-insulin ratio and see if we can work our way across the day, changing those carb-to-insulin ratios a little bit to get those numbers back down, okay? So, and nowadays, you know, most meters, you can download them if you have the capability in your office, and so you can get a wealth of information if they're checking their blood sugar. Oftentimes, we'll get, you know, a month and there might be 10 blood sugars at all different times, so it makes it really hard to tease it out. Okay, so that's what I have for diabetes. We do have a case that Raquel sent in. Raquel, do you want to give a brief history of any of the questions or cases? Okay, well, thank you for joining us.
All
All right, we'll see you next time.
Have a great day.